Assalamu alaikum. My name is Dr. Ayman Raweh. I'm a cardiac surgeon in Klinikum Dortmund in Dortmund, Germany. And today I'll talk about biological valves and compare them to mechanical valves in the modern cardiac surgery. So around the world, there are 200,000 heart valve operations done every year. And in every operation, there's a discussion with the patient about which heart valve procedure should be done. And it always starts with, can we repair this valve or should we replace it? And for example, in mitral valve prolapse, which is when the mitral valve is leaking, in many cases, we can do a repair and we don't have to do a replacement. But in the case of aortic stenosis, for example, we have to do a replacement. But even when we decide that we want to repair the heart, the valve, we should have a backup plan of replacing the valve just in case we cannot repair the valve. So then comes the other question, should we use a mechanical or a biological valve? So a mechanical valve is made of carbon polymers and it has metal in the ring, and the biological valve is biological tissue. But before I talk about mechanical and biological valves, let me show you the overview of decision making. So this is the tree for decision making, how we decide. For example, if we have a patient with aortic stenosis and this patient has a high risk, the operation is risky for him. So we should go for TAVI because TAVI is done with the catheter from the leg and it is easy for the patient and they recover very fast. So for high risk patients, we should use TAVI. But then in low or medium risk patients, we have to decide depending on the age. For example, if you have a patient younger than 50 years old, you should go for a mechanical valve because those patients with mechanical valves may live longer than younger patients with biological valves. They have better survival. And if the patient is older than 75 years old, you should go for TAVI because these patients have high risk in the operation. But then in the age between 50 and 70 years old, this is the whole discussion about this topic. It should be a shared decision making between the doctor and the patient. The doctor should explain to the patient what are the mechanical valves and what are the biological valves, and what are the benefits of each one and what are the disadvantages. But also in biological valves, you still have to decide if you should go for TAVI or surgical valve replacement. So when the patient is older than 65-year-old, you can do TAVI, and there are good data about that. But for younger patients, when they are younger than 65-year-old, we do not have data about the durability of TAVIs in younger patients. So we go for the surgical option. And now the mechanical valves. So as I said, they are made of carbon polymers and titanium in the ring. So those valves are durable, they last forever, and you can implant it in the patient and it lasts until the end of his life. They are the most durable valves that we have, but blood can coagulate on the surfaces of these valves because they are foreign bodies. And because of that, you need to use Marcomar or warfarin. And these medications can cause bleeding when the level is too high in the blood. So the patient has to check. He has to go once a week or once every 2 weeks to his doctor, or he can use such a device, QuagaCheck, to check at home and take this medication. And he has to do that for his whole life. And also another disadvantage of the mechanical valves is the clicking noise. In some patients, they have this clicking noise and it can be annoying. Also, the mechanical valves are not suitable for young women of childbearing age because marcoma and warfarin are not good for pregnancy. They can injure the embryos. On the other hand, the biological valves are made of biological material. In this case, for example, bovine valves, they are made of the pericard of the cows. Pericard is the bag that holds the heart inside of it, and it's like leather that you can cut in the shape of leaflets and make those valves, and they are really good valves. There are many options of biological valves. And the company, like the company Edwards, for example, has many options. So the benefits of biological valves is that they do not require anticoagulants like mechanical valves, but they wear out. They start to degrading and they calcify, and after about 10 to 15 years, they need replacement. And age does impact the durability of those valves. If you have an older patient, the biological valve will last longer in those patients. But if the patient is young, it will not last that long because it will be under a lot of pressure because the heart is pumping much better. So in younger patients, the biological valve may last about 6 to 8 years, and then you need replacement. But because you do not use marcoma or warfarin, those valves are suitable for women of childbearing age. But even if you need replacement for the biological valves, you can do it with catheter. You don't have to do a surgery again, and you can do the valve-in-valve operation, which is easier for the patient. So this is the biological valve, for example, and then with the catheter, you can push all the valves on the side and then insert a valve-in-valve. And the circular ring of the older biological valve will be helpful in this case. So what are the types of biological valves? This is the first one, which is the xenograft. It's from biological material from animal organs, and there are many types. Under the xenografts, you have, for example, the normal biological valves. You have the sutureless valves like Intuity, and many other types, but all of them come from animals. You can use a cow, or there are also pig valves, but the pericard biological valves from cows are pericard biological valves are much better. And then the other type of biological valves is the homograft, which is from another humans. You can excite them from cadavers or obtain them during heart transplantation, but they are really hard to get. Also here in Germany and in Europe, they are really hard to get. And then you have the autograft. And in this case, you take a graft from the patient himself. For example, you can use the pulmonary valve and use it in the position of the aortic valve. And this is called the Ross operation. The autoimmune reaction in such an operation and in such graft is very minimal. So those grafts last longer. They have the best hemodynamics among all biological valves, and they can grow with the patient himself. So this is a good option for patients, for young patients. But the problem with Ross operation is that it's very difficult and very demanding. So it is not done that much. So which valve is better, biological or mechanical valves? Actually, both of them have excellent hemodynamics. Both of them are really good. But to choose, you have to depend on the lifestyle of the patient himself. If you have a 55-year-old patient and he's active, he's working, and he do sport, and he can injure himself. So you do not want this patient on Marcoma or warfarin because he can bleed more. So you do not use a mechanical valve with such a patient. You will use a biological valve. But if you have a 75-year-old patient, if you implant a biological valve, it can last until the end of his life. So it would be a good option. And age remains a critical factor in deciding which valve to choose for the patient. As I said before, for younger patients in their 40s and 50s, mechanical valves have better survival for those patients in comparison to biological valves. There was this large study done in California and published in New England Journal of Medicine, and it showed clearly that younger patients in the 40s and 50s have better survival and less mortality when mechanical valves are used compared to biological valves. This is in the case of aortic valves, and in the case of mitral valve, it can go up to the age of 70. So the patients with mechanical mitral valves until the age of 70, they get better survival in comparison to patients with biological valves. And thank you very much. If you have any question, you can ask me or you can contact me.
Thank you.
Vielen Dank, Dr. Ayman. Und
Gerne.
ich freue mich zu sehen in unserem Bundeswehr Krankenhauskonferenz. Und ich hoffe, Sie zu sehen in Yemen. Vielen Dank. Inshallah. Vielen Dank. Dankeschön.
شكرا.
عفوا الآن next speaker نتيجة الاختلاف في المحاضرات بيقدمها دكتور سيزدينوكي جينو is the chief of medical specialist of Hungarian Society of Cardiac Surgery and president of the Hungarian Fundamentation of Cardiac Surgery.